Hello friends, welcome to the CPE program. The topic we discussed today is the risks of long-term use of proton pump inhibitors. So what are these proton pump inhibitors? So proton pump inhibitors are members of class of medications whose main action is a profound and prolonged reduction of stomach acid production. They are the most potent inhibitors of acid secretion available today. This group of medications followed and largely superseded another group of medications with similar effects but a different mode of action, the H2 receptor antagonists. The class of proton pump inhibitor medications is on the WHO list of essential medicines. Today, the PPIs remain among the most widely prescribed medicines in the world. PPIs as a class of medicine also have a high prevalence of being prescribed for poorly defined reasons or for conditions where PPIs have not been shown to be beneficial. The current evidence suggests that PPIs are often overused, with around 25 to 70% of prescriptions having no appropriate indications. However, stomach acids are needed to digest proteins, vitamin B12, calcium, and other nutrients. And too little stomach acid causes a condition called hypochlorhydria, that is low level of hydrochloric acid in the stomach. Now we'll see the history background of this category of drugs. So proton pump inhibitors were developed in the 1980s, with omeprazole being launched in 1988. So most of these medications are chemically benzimidazole derivatives related to omeprazole. Since 1989, the management of gastroesophageal reflux disease and other acid-related disorders was revolutionized by the introduction of proton pump inhibitors into clinical practice. Now we see some of the clinical uses of these drugs. Dyspepsia, peptic ulcer that are induced by the drugs like MSAID, as a part of Helicobacter pylori irrigation therapy, gastroesophageal reflux disease, Barrett's esophagus, eosinophilic esophagitis, stress gastritis, and ulcer prevention in critical care, gastrinomas, and other conditions that cause hypersecretion of acid, including Zollinger-Ellison syndrome. Now you can see the pictures diagram which shows the proton pump inhibitors are used to manage gastroesophageal reflux disease and other acid-related disorders. So whenever the sphincter of esophagus opened, the acid tend to goes up and causes irritation and pain. So this pain causes irritability, sometimes leads to vomiting and other conditions. So whenever reflux, gastric acid tend to go up. This is a condition called gastroesophageal reflux disease. Now we'll see how this kind of drugs acts, mechanism of action. So proton pump inhibitors act by irreversibly blocking the gastric proton pump called hydrogen potassium adenosine triphosphatase enzyme of the gastric peptide cells. The proton pump is the terminal stage in the gastric process secretion, being directly responsible for secreting hydrogen ions into gastric lumen, making it an ideal target for inhibiting the acid secretion. So targeting the terminal step in acid production, as well as the irreversible nature of the inhibition, results in a class of medications that are significantly more effective than H2 antagonists. And reduce gastric acid secretion by up to 99%. Usually, these PPIs are given in an inactive form, which is neutrally charged, lipophilic nature, and readily crosses the cell membranes into intracellular compartments like the parietal cell canalicus with acidic environments. In an acid environment, the inactive drug is protonated and rearranges to in active form. As described above, the active form will covalently and irreversibly bind to gastric proton pump and deactivating it. So we'll see pharmacokinetics. The absorption of omeprazole, lansoprazole, and esomeprazole is decreased and delayed by food. So it has been reported that these pharmacological effects have no significant impact on the efficacy. PPIs have a half-life in a human blood plasma of only 60 to 90 minutes. Because they covalently bind to the pump, the half-life of their inhibition of gastric acid secretion lost an estimated 24 hours. Its duration of action is 24 hours. So because of this, now we'll see the ADR effects. Background first. Their superb efficacy and low toxicity resulted in the approval of the first OTC product in 2003, providing patients with an option other than antacids and gastroantagonists for self-medication of ailments such as heartburn and other related symptomatology. So these same factors have also contributed to their overuse and misuse, used to indiscriminate usage. Healthcare providers are often prescribing these agents for prolonged, even lifetime use. Many patients are taking the OTC agents beyond the recommended course of therapy without any supervision. These are the main inappropriate uses of these PPIs. Number one, for the prevention of gastroduodenal ulcers in low-risk patients. Number two, low-dose steroid therapy without additional risk factors. Third one, systemic anticoagulation without additional risk factors for gastroduodenal injury. And the over-treatment of functional dyspepsia. Now see the potential adverse effects of this. So over the years, there has been a growing concerns, and also since 2010, the FDA has issued a various safety warnings regarding potential adverse effects associated with long-term therapy of PPIs. So some of the concerns are as hypergastrinemia, development of pneumonia, dementia, and drug interactions. Also, these are some safety warnings regarding potential adverse effects. Risks of fractures, hypomagnesemia, Clostridium difficile associated diarrhea, vitamin B12 deficiency, acute interstitial nephritis, and cutaneous and systemic lupus erythematosus events. Now we'll see in detail one by one. So first we'll take hypergastrinemia. So gastric acid suppression leads to hypergastrinemia. For this, we should know the regulation of gastric acid secretion. So gastric acid secretion by parietal cells of the gastric mucosa normally stimulated by the acetylcholine, histamine, and gastrin. The receptor-mediated binding of acetylcholine, histamine, or gastrin results in the activation of protein kinases, which in turn stimulates the proton pump to secrete hydrogen ions in exchange for potassium into the lumen of the stomach. So hypergastremia causes rebound hyperactivity after discontinuing PPI therapy. So patients may experience worsening of gastroesophageal reflux symptoms. To avoid this, PPI should be slowly tapered. In addition, hypergastrinemia can cause beta cells to hypertrophy and enterochromaffin-like cells to undergo hyperplasia. So these effects may increase the risks of gastric cancer, but this relationship has mostly been observed in vitro. Now we'll see community-acquired pneumonia. PPI use has been associated with increased risk of developing community-acquired pneumonia. So acid suppression leads to an increase in gastric pH, allowing for the overgrowth of non-Helicobacter pylori bacteria in gastric juices, gastric mucosa, and the duodenum. So this can potentially lead to microaspiration and lung colonization. PPIs also impair immune defense mechanisms. So the therapy should not be withheld from patients with pulmonary disease if indicated. It is important to ensure that the patients who are at high risk for the community-acquired pneumonia, including immunocompromised patients, elderly, smokers, and those with COPD and asthma. So they should receive their annual influenza and recommended pneumococcal vaccines then and there. Dementia or condition or ADR. So recent data suggested that there is a link between PPI use and dementia. So biologically, PPIs may increase the production and degradation of amyloid and bind to protein. So the possibility of reduced levels of vitamin B12 and other nutrients may also play a role in the increased risk of dementia. These observational studies suggest an association, but no causal relationship has been established. Now we'll pass on to drug interactions. Several significant drug interactions are associated with PPI use due to their ability to dramatically reduce gastric acid production, thereby raising gastric pH. So medications that require an acidic environment for absorption may have reduced oral bioavailability in patients treated with PPIs. Some examples of agents that may be affected and have reduced efficacy, namely itraconazole, ketoconazole, isoniazid, oral iron supplements, and several protease inhibitors. Several studies have suggested that the PPIs may inhibit the hepatic cytochrome involved in the metabolism of certain medications, raising concerns of additional drug interactions. Recently, attention has focused on the potential of PPIs to inhibit cytochrome 2C19 and adversely affect the prodrug clopidogrel when being metabolized to its active form. Theoretically, such an interaction could reduce clopidogrel's antiplatelet effect and lead to increased risk of cardiovascular disease, that is bleeding. Image. One suggested mechanism of cardiovascular effects is because PPIs bind and inhibit dimethyl arginase. The enzyme that degrades asymmetric dimethyl arginine, resulting in higher ADMA levels and decrease in bioavailable nitric oxide. This nitric oxide is a naturally occurring molecule found in a variety of cell types and organ systems. Nitric oxide is an important determinant of basal vascular flow, which prevents platelet activation, limits leukocyte addition to the endothelium, and regulates the myocardial contractility. Now we move on to fractures. So findings from epidemiologic studies have suggested an increased risk in hip, spine, and wrist fractures in patients on high doses and long-term therapy. A causal relationship has been noted between acid suppression and reduced absorption of mineral calcium in the diet. There may be as much as 41% of reduction in calcium absorption after 14 days of omeprazole therapy. Although findings from various studies have been inconsistent, there is enough evidence to prompt revision of PPI label to include information about possibly increased risk of fractures of the hip, wrist, and spine. Given the significant morbidity and mortality from fractures, especially hip fractures, risks and benefits should be considered prior to initiating treatment with high dose or long-term therapy in vulnerable patient populations. The lowest effective dose and shortest duration of therapy should be used to minimize the risk. When calcium supplementation is used in conjunction with PPI therapy, citrate formulations should be considered rather than the carbonate to maximize the bioavailability. Now we see hypomagnesemia. Although rare, hypomagnesemia is associated with PPI use. The same time can be life-threatening. The symptoms include muscle weakness, cramps, tetany, convulsions, arrhythmias, and hypertension. Patients may also present secondary hypokalemia and hypocalcemia. Since 2006, there have been fewer than 30% reported. However, PPI's users appear to have a 40% higher risk of hypomagnesemia. Upon discontinuation, magnesium levels normalized within 1 to 2 weeks, but reoccurred within the days after attempts to restart therapy. Most cases were associated with the duration of therapy, 5 or more years. So baseline serum magnesium levels should be obtained prior to initiating long-term therapy and monitored periodically thereafter. So caution should be taken when co-administering with other agents that may lower magnesium levels, such as digoxin and diuretics. Clostridium difficile infections. So gastric acid is an important defense mechanism against pathogens colonizing the stomach and intestinal tract. Recently, there has been concern regarding an increased incidence of Clostridium difficile infections in PPI users. This increase could be attributed to the higher gastric pH, which could lead to a more virulent strain of bacteria. The delay in gastric emptying can prolong the exposure to the bacteria. PPI should be used with caution in patients who are at an increased risk for Clostridium difficile, including immunocompromised patients, elderly, hospitalized patients, and those who are taking broad-spectrum antibiotics should be considered an H2 receptor antagonist and alternative to PPIs. Although Clostridium difficile spores are relatively resistant to gastric acid, the long-term gastric acid suppression with PPIs may alter the colon microbiome to decrease colonization resistance or other normal barriers to Clostridium difficile proliferation. Micronutrient deficiency. First, calcium. The acidic pH in the stomach facilitates the release of ionized calcium from the insoluble calcium salts. So long-term PPI use has been linked to a decrease in the internal absorption of calcium. This mechanism does not influence the absorption of water-soluble calcium salts when contained in complex foods like milk or cheese. Omeprazole specifically has been evaluated with the tracer methods and found that it may impede or inhibit absorption of calcium carbonate in older women. Now we'll see vitamin B12. So gastric acid is important to absorption of dietary vitamin B12. Yeah. In the acidic environment, A2 stomach helps to release the food-bound vitamin B12 and facilitates binding with intrinsic factors to be absorbed. Small absorption of vitamin B12 may result from atopic gastritis and acrohydria, promoting a bacterial overgrowth that allows for the reduced digestion of copalamin. There have been some data to suggest an association between long-term PPI use and vitamin B2 deficiency, especially in the elderly people. So routine screening of vitamin B12 may be considered in the elderly. Malnourished patients receiving long-term therapies, since this patient's population has a higher prevalence of vitamin B12 deficiency. Acute interstitial nephritis. There have been case reports that have associated PPI use with the development of AIN, acute interstitial nephritis. This is a humoral and cell-mediated hypersensitivity reactions that can occur within the days of the therapy initiation and as long as 18 months thereafter. Upon discontinuation of PPI, most patients spontaneously recover. Patients should be educated about the symptoms of AIN, including nausea, vomiting, fatigue, fever, and hematuria, blood. The onset is usually insidious. It's gradual. PP should be discontinued if AIN develops. Some acute, subacute cutaneous lupus symptoms. So drug-induced subacute cutaneous lupus symptomatis is usually resolved after discontinuation. This condition is typically occurring in some exposed areas where neck, back, upper extremities. High risk for developing SCLE include women of childbearing age, those with drug allergies or previous episodes of SCLE, photosensitive skin, exposure to ultraviolet radiation, and family history. So, finally, the beneficial effects and the possible adverse effects need to be balanced like this. So, the picture shows therapeutic on the left side and the adverse effects on the right side. That should be, they need to be balanced. These two. We come to conclusion now. Keeping our revenues to management of isolated diseases. There is a strong evidence supporting the superior efficacy and overall safety profile. Unfortunately, this has led to the overuse and inappropriate use. When used appropriately, the overall benefits significantly outweigh the potential risks in most patients. Almost half of the patients taking PPI do not have a clear indication. Nearly all adverse effects associated with PPIs occur among patients who receive long-term therapy. Patients are in an ideal position, pharmacists are in an ideal position to ensure appropriate and effective use and reduce PPI overuse. Through effective counseling and provision of medication therapy management sessions, pharmacists can ensure that the PPI use is associated with appropriate indications, replacing the lowest effective dose for the shortest duration of spray. So with this, we come to the end of the session. Thank you.